My name is Arif Ansari. I'm one of the neonatal registrar in St. Michael's Hospital, Bristol. So today we have Dr. Professor Karen Luyt joining us. She is a professor of neonatal medicine in the University of Bristol and consultant neonatologist, St. Michael's Hospital, Bristol. Dr. Karen studies medicine in South Africa, and she is specialized in neonatal medicine in UK in 2004, and since then she is working as a consultant in our unit. Dr. Karen's research focus is basically more improving child survival and reducing long-term neurodisability through healthcare quality improvement, and leads NIHR applied research collaboration West's healthcare childhood theme. Key contributions being the PRECEPT program, which clinical lead and chief investigator for the National PRECEPT program, and optimizing magnesium sulfate for fetal brain protection in England as a part of PRECEPT study, and PERIPrem initiative, which is the prevention of the improving the outcome in extreme preterm babies, reducing their brain injury and mortality, and also she's the director of National Child Mortality Database since its inception in 2018. So we requested Dr. Karen, and she happily kindly accepted to attend and share her work and take the questions. Over to you, Dr. Karen.
Thank you, Arif. Thank you very much for inviting me to speak, and hopefully you can share this recording with many people. So I'm going to talk today, and I'm going to share my slides. Hopefully that can be seen by everybody. I'm just going to go into the slideshow. Is that all visible?
Yes, we can see that.
Great. Okay. So I'm going to talk about the PERIPrem care pathway or care bundle, which is designed to reduce preterm mortality as well as preterm brain injury. And I think it's relevant to all units around the world who look after babies. Preterm below 34 weeks is what this care bundle's aimed at. And I think it's suitable for people who can provide basic high dependency and intensive care to newborn to preterm babies. I will also talk a little bit later about an adapted care pathway, which is aimed more at low and sort of middle resource settings where teams might not be able to provide high dependency or intensive care to preterm babies. So if you want to, there's a QR code there that will take you to the main web page for the PERIPrem program, and there's a lot of resources available there, which is free to download if you're interested. Now, we all work, Arif and I, in the National Health Service, so all neonatal intensive care units in England, which is a population of 60 million people, is in the National Health Service. And the National Health Service brought out a policy in 2015, with an aim to reduce newborn brain injury and newborn mortality by 25% by 2020 and by 50% by 2025. So that was the end of last year. And the PERIPrem bundle was very much designed to try and achieve this. Now, I'm going to put up this quote by Aristotle because I think it's very relevant to what we do in neonatal intensive care. Excellence is never an accident. It is always the result of high intention, sincere effort, and intelligent execution. It represents the wise choice of many alternatives. Choice, not chance, determines your destiny. And I think it determines the destiny of the baby. So using evidence-based interventions that we can, implement in a highly structured way is what is the way forward to reduce mortality and brain injury. Now, you may know this, but being born very preterm is the leading cause of cerebral palsy, severe brain injury, but also of child mortality, and this is worldwide. So it's not just in England. If you look around the world, if you look at the WHO work, it is the leading cause of child mortality and brain injury. And if we look at the Global Burden of Diseases study published in The Lancet, what we can see is the condition right at the top, and this is across all age groups, across more than 150 countries that are able to collect data. The leading cause of disability-adjusted life years lost, so years lost to disability, is not ischemic heart disease in adults or strokes or lower respiratory infections or diarrhea or COPD or road injuries, diabetes, HIV/AIDS. No, right at the top is neonatal disorders. And the main one contributing there is prematurity. And the reason because it's up there is if a child survives because of severe prematurity and they have a brain injury, they tend to live for a long time with disability, and so it adds up. And that's why it's the leading disorder in the world causing disability, years lost to disability. So this is what preterm brain injury looks like. If I talk about severe preterm brain injury, it's the severe intraventricular hemorrhage here on the left and in the middle. We can see this is a grade 3 IVH here with blood in the ventricles, bilateral and dilated ventricles. And you can see why this is not good for the brain. You can see the iron staining in the white matter all the way around these ventricles. So this is why this is such a devastating condition for a preterm baby if we have a severe IVH. In the middle here is a grade 4 intraventricular hemorrhage where we've got blood in the ventricles, but we've also now have a venous infarction. So this cauliflower that you can see on the ultrasound here at the bottom, that means the parenchyma here is necrosed, and this is going to form a cyst, porencephalic cyst, and it's this is very, very high risk for cerebral palsy, hemiplegic cerebral palsy. And then here on the right-hand side is what we call periventricular leukomalacia, white matter injury of the preterm, and it's a cystic form. So we can see these cysts forming in the white matter, and on ultrasound it's very visible. When we see this type of ultrasound, we can be very, very sure that this child is going to develop motor impairment, cerebral palsy. Now, these conditions are preventable, highly preventable. There's a big evidence base behind it, and that's what the PERIPrem care bundle is based on. So in the developed world, costing has been done on the cost of cerebral palsy, so the healthcare costs over a lifetime. This was done in Denmark quite a while back, but there's an estimated around, what we say is £1 million per baby for the lifetime cost of cerebral palsy. Of course, it varies depending on the degree of cerebral palsy, but that's the average cost to the health service. And of course, that doesn't measure the impact on the family and on the individual. That's purely the health economics around cerebral palsy. And that means if you can prevent cerebral palsy, that is very cost effective. Now, in 2019, data were published in England looking at severe neonatal brain injury, and it was presented by the different regions, and we're in the southwest region of England. And we were a little bit surprised to find that we actually had the second highest, here in yellow, neonatal brain injury rates in England. And we consider ourselves to be a region, with quite high standards of care, high quality of care. And then we went and we looked at our data and we drilled down into this. And what we found is that this was not term brain injury caused by hypoxic ischemic encephalopathy, but actually this was preterm brain injury caused by the severe IVH and cystic PVL, as I showed you there. And we then got together as a group in the southwest. So this is the southwest region. You can see it's a large geographic area, 12 different hospitals, and St. Michael's is here in Bristol. And we have 3 tertiary level intensive care units. So that's 2 in Bristol and 1 in Plymouth. And then we have 9 smaller hospitals with units that can deliver high dependency care. And this area has a catchment, it's 8% of births in England. So this is a population of 5 million. So it's about the size of a country like Norway or Scotland. And what we did was these hospitals got together, all of us, together with parents who'd experienced having a preterm baby. And we faced this problem that we had of having a high preterm brain injury rate. And we agreed that we needed to do something about it. We looked at the evidence base, so looked at everything published on ways to reduce mortality and brain injury, because that was our goal. And we then put together this PERIPrem care bundle, which is basically 11 interventions. And some of these already start delivered by the obstetricians. Some of them are shared, like optimal cord clamping is both an obstetric and a neonatal intervention. And then the rest of the things is what we give on the neonatal unit. And this was funded by our Health Innovation Network. And the aim was to reduce brain injury or death by 50%. And we aimed this care bundle at, babies of 34 weeks gestation or below. And what we included in this care bundle was the place of birth. So what this means is if you have advanced warning that the baby is going to deliver preterm, move the baby in utero to a suitable unit that has the level of intensive care unit for the baby that can manage that particular baby. And in England, what that means is if a baby is below 27 weeks gestation, they get moved in utero to a tertiary centre like St. Michael's, where we can deliver everything that's required for a small baby. And we take babies down to as low as 22 weeks gestation. And we aim to move these babies in utero, not ex utero, because moving a baby ex utero actually causes harm compared to in utero. Your chances of developing severe IVH or cystic PVL or dying are significantly higher if the baby is not delivered in a tertiary unit. The second intervention is antenatal steroids, very old intervention. You know this probably. The original trials were from the 70s. But we're not actually very good at using antenatal steroids optimally. So that means giving a full course of antenatal steroids within the 7 days before the birth. That's when they work optimally. And steroids reduce severe IVH by 50%. So it's a very, and of course it reduces mortality as well by about 50%. So it's a cheap drug and it's very effective as long as you use it in the 7 days before the birth. The third thing is antenatal magnesium sulfate. So this is also a drug that we give to the mother as either as a bolus, a depot into the intramuscular, or as an infusion. And it's given before the preterm birth. It crosses the placenta and protects the baby's brain. It also reduces severe intraventricular hemorrhage, and it reduces cerebral palsy by 30%. So it is a very cost-effective drug. Also cheap, completely generic drug. In England, it costs about £1 for a vial of magnesium sulfate. The fourth thing is intrapartum antibiotics. And so any mother in preterm labour gets antibiotics now to cover group B strep because the likelihood of the baby getting infected and possibly developing meningitis is quite high. So you will notice these 4 things, the first 4, are all under the control of the obstetric and midwifery team. So this is why it's very important, if you're aiming to improve outcomes in your countries, in your units, as neonatologists, we can't do that on our own. We have to work in a team, what we call the perinatal team, which is the obstetricians, the midwives, neonatologists or pediatricians, and neonatal nurses, all working together to improve the care for the baby. Then the 5th thing is optimal cord clamping. So this is instead of clamping our umbilical cord straight after birth, which is the temptation if you're dealing with a tiny baby because you want to get them away and start, intubating and do what you need to do, start CPAP. There's high-level evidence that if you wait for minutes before you clamp the cord, that you actually reduce mortality by 30%. So it's a very cost-effective, it's a cheap intervention, easy to do. But again, you need to work and start practicing, if you're not already doing this, in your delivery rooms where you've got the obstetrician and the midwife delivering the baby. How does the neonatal team fit with that? Make sure that you've practiced it beforehand so you can deliver oxygen or CPAP if you need to do it. So it's easy to do once you've practiced it. And in the if you scan the QR code, we've got all the different elements here. We've got videos and webinars around how to optimize that element of care. So you may find that useful. And then hand in hand with optimal cord management is keeping the baby warm or optimal temperature, not overheat them, not make them cold. When you start doing delayed cord clamping, it's quite easy to get the babies for them to be cold. And so it's very important to do this, all together, ensuring that you're keeping normothermia. Because if the baby gets cold, the risk of mortality goes up significantly. And then the 6th thing is early maternal breast milk. So we get the mothers expressing, if we know it's going to be a preterm baby, planned birth, they can already start expressing before birth. And we try and get colostrum into the baby orally or down the NG tube within 6 hours of birth. And this is really important. And this also needs a team to be, trained to do this. You need your midwives completely focused on assisting the mother with expressing. You need to have a system to get the colostrum, the first milk, expressed back into your neonatal unit if the mother's still in a delivery room. So you need to have the logistics to do this. And it's actually not that easy to achieve. But it does make a difference to certainly the outcome of the baby, better neurological outcomes and better survival. So maternal breast milk, fresh breast milk, protects against necrotizing enterocolitis, against infection, and it gets the baby onto full feeds far quicker than using formula. And then the next intervention we give on the neonatal unit is giving prophylactic caffeine to the baby. This obviously stimulates breathing, but it's also a drug that's neuroprotective. So caffeine reduces cerebral palsy by 30%. It's also a very, very effective drug. Then the next intervention we use is probiotics. So we use that in England. It's a multi-strain probiotics that we use, and we give this with the first feed. And probiotics also reduce mortality by 30%. And because it prevents necrotizing enterocolitis and late infection, it also protects the brain against cystic white matter injury. And then the second last intervention is how we ventilate babies. So we use a volume mode, which is the big meta-analysis around this, the Cochrane meta-analysis showed that for every baby you ventilate using a normal pressure delivered mode versus a volume guarantee mode, you can actually, for every 10 you ventilate with a volume mode, you prevent severe IVH or severe cystic PVL. So it's a very effective intervention to reduce brain injury in preterm babies. And the reason for that is that if you're using a volume mode, when the lung compliance changes, the the carbon dioxide level in the blood does not change, and it's CO2 and which causes big swings in blood flow to the brain. And so if you can maintain that consistent with the volume mode, you're less likely to develop brain injury. And then the final intervention is low-dose prophylactic hydrocortisone that we give only to babies below 28 weeks. And this is given for the first 10 days of life. It basically, many of these babies have low cortisol levels because they're extremely preterm. And this is an intervention that also reduces mortality by 25%. It also improves neurodevelopmental outcome. So this is the entire care bundle and the evidence base behind it. And this is just a different way of explaining this. And the evidence base really originally for PERIPrem came out of this paper, which was published. So Adam Smith Collins and myself, both consultants at St. Michael's, supervised one of our registrars who wrote the paper, and it brings together the entire evidence base to reduce brain injury for preterm babies. And this was already in 2017. And we haven't really, everything we've discussed, I've just discussed is actually in this paper. So there's nothing new about what we're suggesting here. But unfortunately, neonatologists and obstetricians, we're so focused on the next magic bullet in terms of, improving care. We love gadgets and new things. And I think we're not very good at actually implementing things that we already know work very well. We tend to move on and start, doing the next research without actually working out whether we are consistently giving the interventions that actually we know work from high-level evidence, published evidence. So in the talk, I've just also put a table. I'll show you, there's a link to the paper where we published this, but this just gives you the level of evidence and all the papers and everything I've told you at the so far in terms of how effective these interventions are. So for instance, being born in the right level hospital for the baby is actually very effective. So the number needed to treat for preventing brain injury is 9. So for every 9 women you move with baby in utero instead of ex utero, for every 9 you successfully move, you can prevent 1 severe case of brain injury. And for death, it's even more effective. And if we look at something like magnesium sulfate, the number needed to treat below 30 weeks gestation is 37. So for every 37 women you treat in preterm labor before 30 weeks gestation, you can prevent 1 case of cerebral palsy. And that's for a generic drug that costs, £1 a vial. In Pakistan, it probably costs less than that. Okay, so as I said, if you're interested, you can scan the QR code. You can go through to the PERIPrem website. There's a lot of information there, all the papers I'm referring to, all the evidence packs so that you can read the different papers. And we've also put in there the different guidelines so that you can just lift this and use in your own hospitals if you would like to do that. So what did we show with PERIPrem? We did do an evaluation. And remember, this care bundle we started implementing in 2020. And as you may remember, that's when the global pandemic struck. And that meant we moved into a mode where we could not visit other hospitals. So, there were severe restrictions on what we could do to try and stop the spread of the coronavirus. So we did actually deliver this whole package of PERIPrem to implement the whole care bundle virtually. So we had share and learn webinars like this one. We did Teams calls, Zoom calls with the teams to try and help them scale this thing up, implement it in their hospitals. We did emails. That's why we developed everything that's on a web-based platform. So it's something that can quite easily be lifted and implemented in other countries. And this is the paper. If you want to go and have a look, it's all our papers are open access, so you can just put it into Google, find the paper, and download it without a paywall. So PERIPrem, what we did was we compared the babies in 2019, which was before we implemented PERIPrem, with babies born in the 12 hospitals in 2021, so after implementation of PERIPrem. And we looked at whether we improved the different elements that I've told you about, the 11 elements. And what you can see is we actually improved almost everything very significantly just by implementing in all 12 hospitals. The things that we didn't really improve were magnesium sulfate, but then we were already very good at that because we had a preceding program called Precept, which ran from 2018 to 2020. So we'd already optimized magnesium sulfate. And the second one we hadn't achieved to improve was intrapartum antibiotics, but this element was added later added on later. So all the ones we set off to do initially, we managed to improve. And what that meant was, before PERIPrem, if we look at that whole care bundle, so every intervention that the baby is eligible for, only 3% of babies actually got the whole care bundle. And that's in a region where we actually think we provide good quality care. And then after a year of implementation of PERIPrem, this was tenfold higher. So we then got to the point where 30% or 29% of all babies got the entire care bundle. Now, it's quite difficult to actually achieve the whole care bundle for every baby because, for instance, if a mother turns up into our units, into a small unit in preterm labor, and she's going to deliver in the next 20 minutes, to get her moved into a tertiary unit is impossible. That hospital then has to deal with it. Antenatal steroids will then not be a complete course either because, of course, it's just been given 20 minutes beforehand. So to get to a full care bundle for every baby is actually jolly difficult. So another thing we use is what we call an optimization score, where you just look at all the interventions that would be required across time for all the babies and what percentage was achieved. And when we started off before PERIPrem, it was 55% of all interventions that a baby was eligible for or a mother was eligible for was received. And after 1 year of the care bundle, it was 78%. So it's highly significant improvement. And what do we learn about doing this care bundle implementation? Well, we learned quite a lot about how teams work. So what we found was the enablers related to successfully implementing PERIPrem was about reflective motivation was the one group. So this is what the feedback says. So this was qualitative research we did by interviewing midwives, obstetricians, neonatologists, and nurses in the region that were all part of implementation. And they felt because PERIPrem had a very clear goal that was shared by staff, and the goal was that we wanted to reduce brain injury and mortality. So there was a strong, clear, and relevant evidence, so a strong evidence base in the literature for this bundle. So that meant people believed in it. They believed it would work. And then they also felt there was credibility in the PERIPrem brand. So because it was delivered by a team of people they trusted. And then enablers related to the physical opportunity. The first thing was protected time. So for people, so every hospital, what we did was we identified a preterm birth team, and these people were appointed. They were people who were enthusiastic about improving preterm outcomes. And it was an obstetrician. So every hospital had a preterm birth team that consisted of an obstetrician, a neonatologist or a pediatrician, a neonatal nurse, and a midwife. And those were the teams that we coached and supported to implement PERIPrem into their hospital. And these people were all given the time to do it. So they were given 4 hours per week for a year to implement PERIPrem with the help of our coaching support from the central unit. They had access to the PERIPrem resources, which is on the webpage. They had access to PERIPrem events, which were the webinars, the learning webinars we supported. They had appropriate physical environment, so we helped them to make sure that they knew how to have the right equipment for doing delayed cord clamping, having the right drugs in pharmacy, having the right guidelines in place to give the drugs. So basically just making sure that the logistics were there. Having appropriate leadership, which is the preterm birth team I've mentioned, and actually having a changed mindset at a team and trust level. So that means in your hospitals, the management team, the overall board of the hospital had bought into this. So they knew this was running. They enabled the teams to deliver. So if something wasn't available, the board knew they had to provide the finances to make it available so that the teams could implement these evidence-based interventions. Because teams on their own can't do this if the hospital is not on board, the leadership in the hospital. And then the enablers related to social opportunity. So this was about having a community of improvement across the whole region that could, work together and support each other. So this is about perinatal team collaboration and communication. So a bit like what we're doing here today. Regional learning and sharing and collaboration. So teams learning from each other. One team going into another hospital that's already doing it well and just learning with their eyes. If you come onto a unit that does things well, it's really, really valuable to spend a day or two or a week to just see what they're doing, and you learn so much from it, much more than you learn from reading their guidelines or books. I always say if you actually can see it, it really makes a big impression. Co-production, so the very fact that this care bundle was developed by different clinical teams and parents who'd experienced preterm birth, and then also senior leadership and trust hospital endorsement, as I mentioned. And I think if you look at this is really, the blueprint for implementing any perinatal interventions, is you need to have all of this in place. And then we also looked at the team culture around perinatal working. We actually did formal assessments before and after implementing PERIPrem, and we found these things improved significantly. The team function, and this is not just the neonatal team, this is the perinatal team. So obstetrics working with neonatal team, with the nurses and with the midwives. Situation monitoring improved, situational awareness, and communication within the perinatal team improved. And then here's the link to the papers where we discuss this in more detail. So as part of this evaluation, we also did a quantitative assessment. And what we did was all our units submit data to the Vermont Oxford network. So that meant we had really good baseline data in terms of brain injury and mortality. And so it means we could see what happened after we implemented the care bundle. And what we did was we looked at all the babies in the cohorts preceding PERIPrem. So this is baseline data 2014 to 2019. And then we looked at the data after implementation of PERIPrem, which was 2020 to 2022. And the outcomes we looked at were mortality primarily, and the secondary outcomes were all grades of intraventricular hemorrhage, severe preterm brain injury, which is the combined group cystic white matter injury plus grade 3 or 4 intraventricular hemorrhage. And then we also looked at intestinal perforation and any late infection as balancing measures. We also did an analysis within the Vermont Oxford UK network. So what we did is then, as a counterfactual, we looked at what happened in the UK in the same time period, 2014-19 as baseline and 2020 to 2022, to see whether things had changed in the UK compared to the Southwest region. And we used chi-square test to compare proportions, and P less than 0.05 was considered statistically significant. So what did we find? So this abstract you can also find, it was presented at the Neonatal Society Spring Meeting. So this block here is the Southwest network, so the 12 hospitals in the Southwest. And the right-hand side block is the UK Vermont Oxford network, which is the hospitals in the UK that also submit data to Vermont Oxford network. And then we're looking at mortality, IVH, all grades, and severe brain injury. These are the outcomes. So we found that mortality was 9.9% in the baseline period before PERIPrem, and that dropped to 6.9% after implementation of PERIPrem. So that's a 3% absolute reduction, and that's a number needed to treat of 33. So that means for every 33 babies treated with a care bundle, we prevented one death. And that was statistically significant. In the UK, over the same period, there was no change. So 15% versus 15%. So the counterfactuals show that this is not just a trend, the general trend that was going on. The Southwest is different. And the only thing we did different is we implemented PERIPrem. IVH, we went from 31% in the baseline period. After PERIPrem, 25.4%. So that's a 5% absolute reduction. And that's a number needed to treat of 20 to prevent one case of intraventricular hemorrhage if we implement PERIPrem. And then the UK VON network, it was really no different, 31% in the baseline period and 32% after. So this had not changed in the rest of the UK. The Southwest was different. Severe brain injury went from 10.1% in the baseline period to 8.4% after implementation of PERIPrem. And in the UK VON network, the baseline period was 10.6% and 10.3% after the period where PERIPrem happened. So that's no different. So what that shows is that actually in the UK nothing had changed, but in the Southwest we have made these improvements. And then the balancing measures, we looked at spontaneous intestinal perforation and late infection. SIPs, because hydrocortisone low dose, it has a side effect potentially of perforation, so we wanted to monitor this. And late infection, same thing with hydrocortisone low dose. You can also the worry is that you would have more late infections. What we found was the SIP rate didn't change before and after PERIPrem. The late infection rate actually reduced. And if we look at the rest of the UK, the SIP rate actually went up. So, which is because we are now rescuing very, very low gestation babies likely, and they tend to have SIPs. And the late infection rate in the UK generally did not improve. So the Southwest is also different. And that's probably because of the probiotics. So probiotics we know are very effective at reducing late infection. So what happened with the neonatal mortality rate in the different regions in England? So this is just data from the National Child Mortality Database from 2019 to 2024. And these are the different regions in England. The neonatal mortality rate here is the dotted line. It's the average rate. You can see it hasn't really changed over time, despite this ambition to reduce it by 50%. In red, we have, this is the Southwest region. You can see we started off, we weren't the lowest in the country, we were in the lower cluster, but we were not that far from average. And you can see PERIPrem went in here, where the arrow is. And you can see, of course, there is variation because it's the numbers are not that high, fortunately. But you can see ultimately we've dropped to being the lowest region in the country in terms of overall neonatal mortality rate. Now, we know a big chunk of neonatal mortality is driven by prematurity. So this is why we've seen a drop, is because we've focused on preterm mortality. And this has persisted. So in the last data, which was 2025, the Southwest was actually the only region in England that reached the 1 per 1,000 neonatal mortality rate that they were aiming to achieve in 2025. And that's because we focused on preterm mortality and we implemented PERIPrem. So this just shows you this optimization score, which means of all the different interventions a baby or a mother was eligible for, what percentage was achieved. We look at it from July 2020, which is when we started collecting the data, and this is across all 12 hospitals. And we've looked, this is up to the most recent data, April 2025, and you can see we've gone up from 55% to 90%. And as of February 2025, 3,400 babies have been maltreated with the PERIPrem care bundle. So the conclusion is that implementation of PERIPrem, a care bundle to reduce mortality and brain injury delivered by a large regional perinatal QI collaborative, so quality improvement collaborative, was associated with an improvement in preterm mortality and brain injury in very low birth weight infants. And preterm mortality and brain injury remained unchanged in the UK over the same period. Just to show you, in the UK we have a neonatal audit project, which all hospitals with neonatal units have to submit data to. And they measure quality metrics, and then you can benchmark your region, so our neonatal network, the Southwest one, against all the other neonatal networks in the UK. So this includes Scotland and Wales as well as England. And this is just looking at mortality 2023. You can see, and this is for babies below 32 weeks gestation, the average mortality in that year for the UK was 6%. But you can see there's quite a lot of variation. These are the different neonatal networks. So there is variation, significant variation. And what you can see here is the Southwest, our region that implemented PERIPrem, is the lowest mortality in the whole of the UK. We weren't there before. So in 2019, we were around this average mark. So we have improved. And then looking at severe intraventricular hemorrhage or death as an outcome, same format. So this is 2023, all the neonatal networks in the UK. The average rates here, 14%. And again, you can see here the Southwest, we're the lowest. And there's significant variation around the UK. We have now implemented PERIPrem into Wales as well. And in the most recent NAP data, Wales has dropped their mortality from, I think, the second highest network in the country down to third lowest. So they have improved as well. And we have also now started to scale up PERIPrem into the two regions, so the West Midlands here and East Midlands. Those are the two regions with the second and highest and third highest mortality rate in the country. They've also now implementing PERIPrem. So we've managed to get funding and support to help these regions implement PERIPrem. So we'll see how they're doing in future. And then cystic PVL or death as an outcome in the NAP again, we've got the same format. So 10%, dotted line there is the average. And again, huge variability, and you can see the Southwest is the lowest. And this is purely as a result of PERIPrem. So I'm going to end by just thanking a big team of people. So this is not my work, this is teamwork. We've got neonatal leads, myself, Sarah Bates, and Sam Moosen. We were neonatologists. We've got a midwifery lead, Anne Remmers, obstetric leads, and then also parent partners that were on the steering group. And we need to thank our funders as well, the Neonatal Network and the two Health Innovation Networks. And we were very pleased to receive the British Association of Perinatal Medicine Award for the best regional or national project to improve perinatal care. And I'll just end by saying, if you look at how to improve perinatal care, these are the clear things we learned from the evaluation. Have a clear shared goal, so know what you're aiming to do. Co-produce your care bundle or whatever intervention you're planning with both clinical teams, doctors, nurses, midwives, obstetricians, and parents. And then develop your perinatal team so that they can collaborate and communicate. So you have a shared community of practice, and give everybody the support to implement. Don't just go and support those that are enthusiastic. It's really important. If you want to deliver equitable perinatal care, you need to actually go for those teams who don't even realize that they're not, doing high quality care. And then for those of you who are interested, PERIPrem's aimed at units, as I said, that can deliver HDU or intensive care. But there's also the PremPrep 5 intervention, which has grown out of PERIPrem, and that's supported by FIGO. You may know about FIGO. I'm sure Pakistan is represented in FIGO as well, or FIGO, which is the International Federation of Gynecology and Obstetrics. And it's 5 interventions that are effective. And it's basically antenatal steroids, magnesium sulfate given as an IM injection, delayed cord clamping, keep the baby warm, kangaroo care, and expressing early breast milk and giving it to the baby. So that's the bundle of care for units who are low and middle resource settings. And I'll finish with this quote from the late great Archbishop Desmond Tutu, who is from my birth country. And he said, "Do your little bit of good where you are. It's those bits of good put together that overwhelm the world. And this is what it's all about. Teamwork, everyone doing their little bit, and then you can improve care and outcomes." And I'm very happy to take questions.
Thank you very much, Karen, for this beautiful presentation. We have Dr. Sajjad raised his hand, sir. Please go ahead with your question, sir.
Thank you very much, Professor Karen Luyt, for the excellent work you have done and the BAPM award you have achieved. This is amazing. Thank you very much. And for the presentation as well, which we were looking forward to for the last 1 month. It was a great learning. Now I have 2 questions. One is about the low dose hydrocortisone for 10 days, you mentioned, and what dose do you use? And the second is about the probiotics, which you said you start from the first feed. So how do you give it, and do you use with the breast milk as well? Thank you.
Yes, so the probiotics we use is a multi-strain. So in the UK, we have 2 products that are produced to high standards, because it is a food supplement. It's not produced to pharmaceutical quality standards in most countries, but we do have 2 products that are high quality in the UK, and we give it with as soon as a little bit of breast milk is available, we mix it and either give it in the mouth or buccal or down the NG tube if there's enough breast milk. You can also mix it with a little bit of sterile water if you haven't got enough breast milk to once you've started feeding, you can put that down the tube as well. And then the hydrocortisone we use. I don't know if your teams have heard of the Premilock studies. So it's a Premilock trial that was published about 6 or 7 years ago. We use that protocol. So it is the twice a day. I want to say it's 500. I'll look that up for you, but it's in the slides I produced. So it's a much lower dose than what you use for treating BPD, and it's twice a day for a week, and then once a day for 3 days. So it's a 10-day course.
Well, BPD, you mean the DART protocol?
No, DART protocol is dexamethasone, but yes. the dose that you would normally use, some people use hydrocortisone for treating BPD, which is the 1 milligram. I think it's 1,000 milligrams in split doses daily. So that's the higher dose, or 2.5. 1,000 milligrams or 2.5 milligrams BD is generally the dose range they use for BPD. And this is much lower than that. So it's 250 milligrams BD is the first dose, and then 250 once a day. It's come back to me now. So it's a low dose.
Thank you very much.
And I think really that drug, if you're interested in using it, what I recommend doing is go and look at the Premilog trial that was published in the New England Journal of Medicine, so it's open access, and just look at the rates of mortality that they had in their control arm of that trial. And if your mortality rates are higher than that, then I think you should consider using it. If your mortality rates are lower, then this goes across for any trials. If your area of interest that you want to improve is better than the control arm of any trial, then it doesn't make sense to actually use that, whatever the intervention is. If your control arm is similar, if your rates are similar to the control arm or worse, then it's likely that that drug will work for your purposes.
Thank you very much. If RF can allow me one more question, Dr. RF.
Yes, sir. Please go ahead. Sure.
Yeah, it is about your protocol of dealing with the significant ductus arteriosus, and how do you treat it, and what is its effect on in reducing the mortality in your cohort?
Yes, so we have moved away completely from active management to the PDA. So my unit is the unit that actually does cardiac surgery as well. So when I started there 25 years ago, we had a duct ligation at least 1 to 2 every month, babies coming in for surgical duct ligation. And the last 5 years, if I look at duct ligations, we've had one baby where we've done a duct ligation in 5 years, where we used to do 2 a month. So we've moved away completely from doing surgical repairs. And the reason what we've done is we've recognized that the baby who comes along with a big duct, usually the story goes, we can't get the baby off the ventilator, the duct's causing lung disease, so we want to close the duct. We say no, we think the duct usually stays open because of the lung disease, because of the pulmonary hypertension. So what we do is we treat those babies with dexamethasone, with DART regimen, we get the lungs better, and then the duct closes. And so that's, the extreme end where you're doing surgical ligation. We don't do that anymore. And then as for treating babies with, we used to use indomethacin. 12 years ago, we were using indomethacin to close ducts. We would actively go and look for the duct echo. If the duct seemed, to be clinically important, if the left atrium was dilated, etc., we would treat it. Then we moved to ibuprofen when indomethacin went off the market. And then we switched to paracetamol, especially in babies where we were worried about NEC, etc., so where the bowel was compromised. Now we use paracetamol, but very rarely. So we don't go and seek ducts anymore. We don't do routine echoes looking for ducts and then treating them. I mean, some people still do. But I think the evidence base now, if you look at all the trials that have looked at treating ducts, the conclusion is clear. If you treat ducts, you do not improve mortality and you do not improve BPD. In fact, the latest, the Oscar study showed actually worse BPD if you treat with paracetamol. So no, we haven't changed what we've done in the PERIPrem era, and I don't think treating or not treating ducts has made any difference to our mortality rate.
Thank you very much.
I think if you focus on improving BPD, so drugs like caffeine, the big trial caffeine study showed big reduction in BPD, chronic lung disease. Hydrocortisone prophylactically reduces chronic lung disease. If you prevent infection, you reduce chronic. So if you focus on reducing chronic lung disease, then your ducts will also close.
Is that all from Dr. Sajaz?
Thank you very much. I'm done. Thank you. I appreciate that.
Next, we have Dr. Saima Pirzada raised her hand. Please go ahead, Dr.
Thank you very much for such a elaborative description and your trial. And congratulations for winning the award as well. My question was about steroids, which Dr. Sajjad already asked, but I have a second component of that question. Do you see more side effects of sepsis or any do you have any parameter for starting hydrocortisone? You just start right away when baby is born and admitted?
Yes, so it's only below 28 weeks gestation that we use it. And we started from day one. So we don't, we don't change what we do depending on sepsis or anything else. What we found is before we started using prophylactic hydrocortisone, we did use hydrocortisone quite a lot for blood pressure. So we would start babies on inotropes if the blood pressure was below, mean equal gestational age. If it was below that, we would start usually dopamine, then add in dobutamine. Once they're onto inotropes, we would then use hydrocortisone as an inotrope as well. So a lot of our extremely babies below 28 weeks would end up anyway on hydrocortisone from about 24 hours of age onwards, and much higher doses than what you use for the prophylactic dose. And so what we found is since using the hydrocortisone, we're actually using inotropes far less. And it makes sense. Some places use hydrocortisone, they select it. If you want to go for the very high risk group, you do it for babies below 28 weeks, but then you look at the babies who've not had a complete course of antenatal steroids. So that's another way of doing it. If you want to be, really targeting your ultra high risk group, you can do that if you don't want to give it to everybody. And then one unit in our region, it looks after a lot of extremely preterm babies, the tiny babies. They don't use it. Their cutoff is 26 weeks gestation. So they've decided to use it just below 26 weeks gestation, not from 28 weeks.
Okay. Thank you. Another question. I just missed initial part of your talk. Did you talk about IVH bundle if you're doing it with Premilo care or no, like the central position, no handling, cluster care?
Yes, so that is part of the care of intensive care anyway. So this PERIPrem care bundle was completely focused on just the highest level of evidence interventions around antenatal, intrapartum, and after delivery. So that's what we focused on for PERIPrem. There are IVH bundles of care, which is about, as you say, how you handle the baby, which are also very important. Most of that isn't so well evidence-based. I mean, it makes physiological sense. We do developmental care of the baby on the neonatal unit with the nursing staff, and how we handle babies is quite set. And the other big thing I think is to positioning of the baby, so making sure that you're not occluding the big venous drainage areas, and that you're also not giving fluid bolus very fast. So, anything like that can increase the chances of developing IVH. But you're right, there are some very specific care bundles focused entirely on reducing IVH, which is not what we're talking about here, but they have been published as well.
Thank you very much. Next is Dr. Durre Shahwar, I think. Please go ahead, unmute yourself and ask the question.
Good day, everyone. Thank you so much for such an incredible knowledge share. I have a question that we discussed about hydrocortisone to be given as a part of bundle. So there is a known correlation of any kind of steroids with difference in blood pressure from the baseline. My question is, we all know that the preemie brain is more, the cerebral blood flow is more pressure passive than the term and late preterm babies. So what was the experience of your team while running this practice of giving hydrocortisone in every such baby with your bundle?
Yes, you're right. So I think the as you're saying there, the autoregulation in the preterm brain is abnormal. And so whatever happens with the blood pressure in the baby, it directly transmits to the brain. So if the blood pressure falls, you get hypoperfusion of the brain. And if the blood pressure surges, you get overperfusion. And that's when you get IVH, isn't it? So with hydrocortisone, you don't see the changes very rapidly. So it's what the trials have shown is you use less inotropes if you use hydrocortisone prophylactically. Certainly that's been our experience. So we used to have virtually every baby below 26 weeks used to be on inotropes on our unit. That's not the case anymore since we've used hydrocortisone. And I think if you're using an inotrope, the chances for surging in blood pressure and dropping is quite a lot, because those drugs are ultra fast working. And if you're just changing an infusion or whatever, you can quite easily get a big drop as the infusion gets interrupted, or if you get a sudden little burst of a surge, then the blood pressure shoots up. I'm sure you've all seen this. So I think the risk is more if you're using inotropes, and I would say if you use hydrocortisone low dose, you use less inotropes. So I'm quite happy to that we're probably doing, and I think that's how it probably works with reducing brain injury.
Thank you so much.
Thank you. So next is Dr. Adnan Mirza, sir. Please unmute yourself and go ahead with your question, sir. Dr. Adnan Mirza.
Thank you very
so
much.
We have sir.
Yeah, am I audible?
Yes.
Yeah, that's great. Listen, thank you, Karen, for the great understanding of the presentation for everyone. I want to ask a kind of experience from your unit that you mentioned to the group that you are using the low dose hydrocortisone initially as an adjunct therapy, or probably a therapy that may need of a decreased use of dopamine and dobutamine later on along with it. I understood that. Will you tell us that in your unit, is there any increase in fungal infection, number one? And is there any increase in the sudden IVH? As you mentioned already, there is sudden increase of this vital drug, sudden use of this drug suddenly increase the blood pressure variability in the babies. That's my first question. Thank you.
Okay. Yes. Now, we've not seen an increase in any late infection. In fact, we've seen a decrease. So fungal infection, our unit has very low rates. And then IVH, we've seen actually a reduction in IVH since we've started with this. So we've not seen an increase.
And at the same time, you are seeing a decrease of chronic lung disease with the use of this medicine.
Our chronic lung disease rates have remained unchanged. So, and I think that's probably because we're seeing more babies survive. So with this care bundle, we have improved survival. And if you improve survival for babies of 24, 23 weeks gestation, which is what we're talking about here, none of those babies survive with our chronic lung disease, because they're all in oxygen at 36 weeks gestation. So your overall chronic lung disease rates, what tends to happen is once you start improving these outcomes of survival, you're probably going to see an increase in your chronic lung disease rates overall. Because for a baby to get chronic lung disease, they have to survive to 36 weeks gestation. Yeah, so we haven't seen a reduction, but we have also not seen an increase, which we would have expected with more extremely preterm babies surviving.
Okay, thank you. And my second question, thank you for this clarification. What would happen if we don't use even below 28 weeks of gestation, if the BP is within normal limit for gestation, that particular mean gestation, for example, 28 weeker, and the mean is 28 week, why would we start hydrocortisone? Why not we just start with the low dose of inotrope? That's my question.
Yeah, I think that's what we used to do, is to start a low dose inotrope. But I don't think inotropes are without their problems. I think you're more likely to see surges in blood pressure and falls if you're on an inotrope infusion. it's an additional intensive care intervention with side effects potentially. And so I think if you can avoid using inotropes, it's probably better for the baby. And the low dose hydrocortisone, we used to use hydrocortisone on top of inotropes if the inotropes didn't work. So that was sort of our third step in third level inotrope once you're on multiple inotropes. Now we just use a prophylactic dose of hydrocortisone right at the beginning, day one, before the baby even starts to develop hypotension. And what we're finding is we're using far less inotropes.
Okay, thank you.
Sorry, if I can have one question?
Yes, please, sir. Go ahead.
Thank you, Karen. Thank you very much. As you all know, and we all are doing almost the same thing. The only thing what I am looking into it, that 28 to 32 weeks, the rate of IVH and the rate of BPD is really low. So 28 weeks and below, 25 weeks and below, definitely I find some, advantage of, hydrocortisone and other things. But all other things we are doing except to give the probiotics and the hydrocortisone. So my question is that 32 weeks and below, are we not doing unnecessarily giving hydrocortisone, probiotics? Because these are the baby up to 28 weeks, mostly requiring CPAP, high flow nasal cannula, come out of it very quickly, and the chances of infection, IVH, is quite low with the BPD. What's your comment on that?
Yeah, I think if you've got low rates, don't use it. Just give it to the below 25 weeks then. As I said, if you've got low rates that are not, don't match the control group in the trials, don't use it. But, and I think, focus on, this is a care bundle of 11 things. If you want to drop one, there's no problem. Go for the probiotics then. Because we do see neck, some of the most devastating neck happens in your, higher gestation, neck totalis. It's often babies that are, 30 weeks, 29 weeks where you see that.
Sure.
Okay. Thank you.
And I wondered if I could just ask as a group, are any of you submitting data to Vermont's Oxford? Any of your units? Because I know there are some units in, I think in India and Pakistan who are submitting data. Or have you? Or do you have sort of audit programs where your outcomes are measured in a systematic way, and the use of your like antenatal steroids, magnesium sulfate? Is there national data on that?
I can comment.
I think from Pakistan is very difficult to tell you about, because the data collection and the data, I don't know, I'm visiting Pakistan very oftenly, but I don't think so there is any one data submission is there, except maybe Adnan can tell us, maybe the AKU is the one member, or Khan University in Karachi. Maybe this is the only one. But the data collection in Pakistan, we are lagging behind. Okay. But in other my units where I am based now, we are the member of the BON and we are submitting on that. So that's why I raised this question, that we have a problem with the babies less than 26, 27 weeker rather than 28 to 32 weeks.
Yeah.
I would add, my name is Dr. Adnan Mirza. Thank you, Dr. Junaid. Yes, he's right. Our research department is quite well developed, and we have quite a good publications from it. The permanent neonatologists who are a researcher in their category for 80%, like one of them is Shabina Arif, and they have the connection, and we are registered with Vermont Oxford in the process, already finishing, but already we have some Cochrane, myself also a kind of collaboration and submission of our research in a proper way. So, and our data department is quite well developed, very well organized, because we have, I think we are the largest, AKU is the largest research group in Pakistan, the medical, with good number of researchers. So I think I agree here that yes, if there is not anywhere else, but AKU has a good data collection, and you can collaborate with us or Dr. Junaid in this regard. Thank you.
Thank you. So it would be interesting to look at, your the things that are not under your control. So the antenatal steroids and the magnesium sulfate and the cord clamping. How consistent that is. Because I think those are the things that are, I think the hydrocortisone is the cherry on top, I would say. I think the other thing, I always say is if your baby's born in the wrong place and they're not optimized antenatally, whatever you do after they come into your neonatal unit, you've lost all that ground. You can give perfect neonatal care from the time they're born, but if that antenatal care wasn't good, you've lost all that ground. If the IVH already happened then because they're born in a small hospital or because they didn't receive antenatal steroids, there's nothing you can do about it. So that's why I think when people start collecting their data in VON, sometimes they get a bit of a fright, because they suddenly realize, gosh, we're not really as good as we thought with antenatal steroids or magnesium sulfate.
I think we have one last question from Dr. Sajid Nazir.
Dr. Sajid Nazir, please, sir, go ahead, unmute yourself, introduce yourself. And
thank you, Arif. Thank you, Arif. So, Karen, can you hear me?
Yes, I can.
So, first of all, thank you very much for a nice talk. And the second thing is that I'm seeing you after a long time, after 16 years. So, I worked in St. Michael's in 2010.
I remember, yes.
Yes, with
wow,
Karen.
Gosh,
Yes, a small world. Fantastic.
It would be good to put your camera on so we can see that. Wonderful.
So
yes.
I don't know whether this works or not. I'm trying, but it's not working. But anyway, we can just talk later. I'm just working on my mobile, but it's somehow not working. So, and a few points, like last 10 years, I've used, because I'm doing echo-guided these inotropes, and I have seen the beauty that more you give inotropes, there are more problems. And when lesser you give inotropes, and if they are echo-guided, I think that's fantastic. So I think giving more inotropes will give more harm in babies. Gentle ventilation is the key. My question to you is that when we are using this hydrocortisone, so in your cases, what is the percentage of this hyperglycemia in these cases? Because sometimes people do worry when you give steroids, they suppress immunity, they lead to some neurodevelopmental issues, and moreover the hyperglycemia. So what's about that?
Yes, the meta-analysis on this doesn't show that actually it increases hyperglycemia, but our experience is that it probably does. So with our babies, we use quite concentrated TPN as well, and we brought that in at about the same time we started with low-dose hydrocortisone. But we do find that babies, particularly, as you're increasing your fluids over the first few days, we quite often in the babies on hydrocortisone have to reduce the glucose input. So I would say it probably does, increase your chances of hyperglycemia.
Okay, thank you very much. Thank you. So hopefully I'll be in touch.
Sajid, your voice, we can't hear you.
I think along with his camera, his audio also died.
So there is another question in the chat from Dr. Naveed. Does the bundle lose its neuroprotective efficacy if we don't implement every element at once? As in lower source centers, there are unique challenges of stuffing, transferring to higher center, and infection risk, etc. So that's the question, all or none. Well, should we implement, if we can't do all of them, should we do some of them, or we shouldn't do at all? I think this is what the question was. Yes,
I would. I think if if you've got challenges like that, I would start with what I call, the Prep 5. So the 5 things which are reasonably cheap and easy to implement, I would say, in a lower resource setting. And so that's the antenatal steroids, magnesium sulfate, delayed cord clamping, keep the baby warm, and very early breast milk. I think if you've managed, you can do those 5 things well in a challenged setting. Then later on, you can look at adding more things in. I think caffeine is an important drug, and I know there are limitations around availability. Certainly in Africa, I know it's a really difficult thing to get hold of. I don't know what that's like in Pakistan, but I think caffeine is one that I would add in if you've got access to caffeine, because I think it does make it's very neuroprotective, but also because it helps the baby breathe. You can then manage the baby on CPAP, and it improves survival. So I think caffeine is one of those quite magic drugs, I would say, if and it's got very few side effects. But it is, I know it's an orphan drug in some countries, and it can be quite expensive. I don't know what it's like in Pakistan, if it's an expensive drug or whether you have a generic drug.
Yeah, anyone can shed some light on that point, please? Yes, Dr. Naila, please unmute yourself, introduce yourself, and go ahead, please.
Assalamu alaikum.
Alaikum salam.
Dr. Arif, I was actually trying to ask a question, and the moment I raised my hand, you asked for a comment. Although caffeine is available in our part and we are using it, but Karen is very right, it's very expensive.
So what alternate you have if you can't use caffeine then?
No, no alternate is there. The caffeine is available, but it's expensive. Whoever can afford can get it, but I don't know that is there any alternate to it is available. We used to do it, used to use it because we are affording it, and I don't know anything about any alternate about.
Arif, can I say something?
If Dr. Naila has finished, then of course.
Yes, I have one question, Karen. In your hello, Karen, can you hear me?
Yes, I can hear.
Although most of us have already said that you described your all project very well, but let me add that I really enjoyed your talk. And I have one question that you mentioned that you had a task of reducing your mortality by 50% by 2025. Have you achieved it or not?
So that was the overall UK or England ambition to reduce newborn mortality, that includes preterm and term babies, by 50% by 2025. No, and it wasn't achieved. And I think the reason for that, we started off with average mortality rate, and we've reduced our mortality rate by 30% in Southwest England. I think potentially this care bundle in areas that have high mortality, if they implemented it, they would reduce by 50%. But no, sadly, England did not reduce their. So the ambition was to get to 1 per 1,000 neonatal mortality, so 1 per 1,000 live births, and England got to 1.5 per 1,000 live births. That was achieved at the end of 2025, but the Southwest did achieve 1 per 1,000.
Okay, and can I comment one more thing, Arif?
Yes, of course. Yeah.
The last data, and you mentioned the comparison between your area and the rest of England. I was just wondering, because all the NICUs, as per sitting in the Pakistan where we are resource limited, and we expect that the NICUs in your area are all well developed and doing well, but the data you showed, there was no difference in the mortality between two two time zones like 2019 one, and I was just wondering why their mortality is just static between and it is the only intervention which you did that made some changes. I was just wondering because the NICUs must be very good, and they should be. I was just thinking maybe they are lacking in some facilities, or can you please put some light on it?
Yes, I think if you look at the Neonatal Audit Project, that collects data on all sorts of quality metrics, including all of these interventions that we've mentioned here, except probiotics and hydrocortisone are not in the NAP data set. There's huge variability in how people use these, even in a highly resourced setting. UK is fifth richest country it is one of the richest countries in Europe anyway. But we still have very poor implementation of certain evidence-based interventions. And if you look at the story of antenatal steroids, it was no different. So antenatal steroids, we already knew was an effective drug to reduce mortality in preterm babies. We already knew that in the 80s. And yet it took 20 years for most countries to start, implementing it effectively. So I think you're right. I think our challenges are probably different in England. Every baby could have access to all of these things. It's not because there's no money to fund it. It's just that clinical teams, it's not a priority. And I think that's a lot we need to learn about. Why is it that clinical teams, obstetricians and neonatologists, why are we so slow at implementing things we know work? Even if you've got the money to buy it, sometimes they're obviously depending on where you're from in the world, there may be restrictions on what you can afford. But in a country where you can afford anything, we can put babies on ECMO if we like, or, we can do heart transplants and, the sky's the limit. But we can't assure that, every eligible baby gets born in the right place and gets antenatal steroids and magnesium sulfate. And I'd be very surprised if you go around most countries in the world and you find that people are good at doing these things. We're about to publish a paper which will be published in 2 weeks' time, coming out in the FIGO journal, so the International Journal of Obs and Gynae, looking at Vermont Oxford data across a number of countries, some high resource, some middle resource, and also comparing private hospitals with public hospitals. And what we can see there is magnesium sulfate we looked at and antenatal steroids, massive variability. Some places are literally not a single baby is getting magnesium sulfate neuroprotection antenatally. So, what this tells me is it's probably everywhere in the world where we're not that good at implementing things.
Okay, thank you. Dr. Sajid raises. Dr. Sajid, are you?
Yes. So can you hear me?
Yes, please go ahead.
Yeah, so coming back to the question of the caffeine, so we do have caffeine. It is the same caffeine which we have used in the UK. So it's almost cost 3,000 rupees per vial, so which is equal to 6 to 8 pounds. But the problem is it's a double-edged sword. And the reason is that if you start a caffeine in a baby and the family is not affording, and somehow even you have supported through charity or whatever the pathway is, the difficult thing is that when we were in UK, we used to have these apnea monitors. So we don't have apnea monitors, and the longer they stay, they cannot afford. And when you send them home, that's a big problem. If they're living a little far from the hospital and they do not have a nearby facility where something goes wrong and they'll go apneic, that's a big problem. And in last 1-2 months, I have seen over 2-3 babies in which it was very difficult to send them home. And when we send them home and they start calling us that the baby is again breathing, differently. So our problem is, one is availability, but when we do have the availability, the patients who can't afford or live far away, they could go into an area where they are in more risk and they do not have any facility nearby to stabilize these babies. So that's the one big problem which we are facing, which we've seen over the years while coming back from UK. Another thing is we have got Prostin, but it's not available in Pakistan as per the recommendation. So it comes to different routes. And I'm using that Prostin as well. But the problem is that sometimes you start it and then availability is not there. So that chain is broken. So coming back to the caffeine, that is the big issue. So without apnea monitors, sending these babies home when they are on caffeine for 2-3 weeks, that's a big issue.
Thank you very much, Dr. Sajid. Dr. Sajjad, sir, please unmute yourself.
Yeah, thank you very much, Dr. Arif. And Dr. Karen, what I see in your 11 interventions, most of these are actually low-cost interventions. And as you have mentioned, that we don't have to do all 11 together or in one go. Probably we can choose a few which suit our needs and our circumstances. So probably the low and middle income countries can devise a bundle of their own based on your experience and implement those. And I'm sure that will make a huge difference. What's your comment about it?
Yeah, because that's all evidence-based interventions. It's absolutely. If you're not doing something already and you can even adopt one, it'll make a difference.
Thank you. I think that's a good message for the low and middle income countries, which includes Pakistan. Thank you.
Even delayed cord clamping costs nothing. Kangaroo care, early breast milk. These are 3 things that cost nothing. You just have to change your practice.
Yeah. Thank you very much. Dr. Safdar?
Yes, I think this was an excellent work and excellent talk, Karen. I just wanted to, for the sake of time, and this is very addicting discussion, I can say that. And I was thinking, is it possible, like if we can find a team in Pakistan who are willing, like obstetricians and neonatologists combined, they can seek your guidance in implementation of some of the bundle items in their units. I think that is what I'm more interested in after listening to you and everything you mentioned. They are all evidence-based. I am here in Columbus, Ohio with Nationwide Children's Hospital. And, we are so spoiled because we get all the things, we don't have issue of affordability, etc. So it's pretty easier to implement here. But I'm looking if we can, there are 2 items I was thinking. One is the Vermont-Oxford Network collaboration from Aga Khan. They can actually, first they need to build a software where they can do the data capturing, and then they can link that and talk to Vermont-Oxford. Actually, Vermont-Oxford provides that software.
Yes, they do. And they have got a new area for, so lower resource settings. So they've definitely got units in Africa as well. So I think they're very keen on this.
Right. So that is something I will be very interested in, finding people who can actually are motivated to actually make that collaboration fruitful. And the second is the NICU aspects and the obstetrician. I think the prenatal care is the key. Some of the things, all you need is the parents to have good prenatal care. And usually the obstetricians, most centers, they're pretty good at least, accommodate some of the common sense things. But I think we have to have some sort of, start at some point. If we feel like, we cannot afford, we will never try. I don't believe in that. I feel like at some point you have to push for things to happen. And I feel like, a country like Pakistan, that is where these things can make a huge difference versus in England, where the room for improvement is not really much. Yeah. And I think that was also related to Dr. Naila's question, why they are not seeing much difference, because they already have stretched enough. And a country like Pakistan, where we have a huge room to improve, I think that is where it can make a huge difference. So that is my comment, as well as, what I learned from the talk.
thank you very much. And I would say, I sit on the FIGO's Preterm Birth Committee. They are focusing for the next 5 years on implementing evidence-based interventions to improve outcomes for premature babies. So they are looking actively for, especially middle and low resource settings, they can work with. And of course, if you can collect VON data, even better, because then you've got very, very structured way of doing it.
Thank you so much. Does anyone has any more questions?
I can't see any hands raised or no question in the chat box. Only Dr. Adnan Yunus has shared the link of hydrocortisone and the Premilog in the chat box. So if someone is interested, can check it over there. So if there is no more questions, should we call it today then?
Yes, and thank you so much, Karen. This is Sunday, and it is from your personal time, and I cannot thank you enough on behalf of everyone here.
Thank you. Thank you very much
for inviting me, and I hope we can make a difference.
Yeah, absolutely. Yeah. So
you have already made a difference to our understanding. Now it's up to our commitment. Thank you very much. Really, very, 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 very nice and appreciate. And thanks for your time.
Pleasure.
And your
good, everyone. Have a good evening.
Thank
Bye. I hope the cricket goes well.
Hopefully.
Not really. Not really. So you can know.
Still there is chance, sir. Never lose.
No, there is no chance. This match is finished. Where is the chance?
Right.
For semi-finals, finals, still there is chance.
Okay. Thank you.
Thank you very much. Thanks, Karen.
Thank you. Thanks a lot.
Thank you.